My dear colleagues, friends, ladies and gentlemen, thank you for joining us this evening for the ICA Wednesday webinar, which has become a hallmark of Indian College of Anesthesiologists. We have faculty of international eminence who will be chairing this session. First will be Dr. Suneel Pooboni, who is very well known all over the world for his expertise in the field of ECMO. He was one of the pioneers. He worked in Leicester in UK, which was the source of the randomized controlled trial on ECMO. And then he worked for a brief while at the KIMS hospital in Hyderabad. Currently, he's working in Dubai, and we are honored to have him as our chief moderator. He is joined by Dr. Jumana Haji, another promising young ECMO specialist, highly talented, working in Mumbai. And then we have Dr. Arpan Chakraborty, again illustrious ECMO specialist who has saved several lives using ECMO in the COVID pandemic. And I'll be with the moderators just to see that everything runs well. Thank you for joining us. And with these words, I would request Dr. Suneel Pooboni to take over and conduct the meeting. There are about 6 short topics: overview, followed by monitoring and maintenance. That will be followed by echocardiography in ECMO. Then we have troubleshooting in ECMO. Then we have a problem, the hypoxemia and venous ECMO. And then lastly, we touch upon complications of ECMO. With these few words, I would like to request our honored moderator, faculty member, Dr. Suneel Pooboni, to take over, and then the questions will be at the end, and any comments and questions will be taken at the end of all the 6 talks. Thank you, sir. Thank you, Dr. Suneel.
Thanks, Murali, for the kind words. I would like to request Dr. Sanjay Patakji for his talk on ECMO overview. Dr. Sanjay is presently he's at Adult Cardiac Critical Care Center, a senior consultant in Narayan Hrudayalaya. Previously, he was professor and head surgical ICU at St. John's Medical Services, Bangalore, and cardiac anesthesiologist at Freeman Hospital, Newcastle. He was also at the Northern UK region for the thoracic organ transplantation team at Newcastle. He has over 42 publications, and he authored several chapters in textbooks of echocardiography, mechanical assist devices, and ECMO. Over to you, Dr. Sanjay. Your time is 15
Good evening,
minutes.
everyone. My talk for this evening is an overview of ECMO. So firstly, what is the definition of ECMO? It's a modified form of cardiopulmonary bypass, which is utilized for the management of severe respiratory with or without cardiac failure. It provides an extended cardiac and respiratory support. But however, the important thing to bear in mind is it doesn't treat the underlying pathology, but just allows support while the disease process resolves or reverses. So this is a picture of one of the first ECMOs which was done in the States. And you can see the amount of gadgetry and hardware which is surrounding this patient. Now, ECMO therapy has come a long way, and then now everything is quite sleek and nice as opposed to when we started off in the 70s. This is a picture of one of the first survivors of ECMO, which was done by Dr. Robert Bartlett. The lady in the picture is Esperanza, which stands for hope in Spanish, and she was the first pediatric ECMO survivor, which was done in 1972. Now, ECMO per se is a bridge. It could be a bridge to recovery, it could be a bridge to transplantation, it could be a bridge to mechanical support, or it could even be a bridge to decision, because sometimes as clinicians, you need that little extra bit of time to make up your mind as to what is right for your patient. The ECMO applications are quite varied in their use. You can use it in cardiac surgery, cardiology, intensive care, as well as in emergency medicine. So when is the first step to start thinking about ECMO? So if the heart is not working and as a result, the lungs are affected and the usual measures are not improving, then you should be thinking in terms of ECMO. Secondly, if the lungs are not working and as a result, the heart is being affected and the usual measures are not improving, then you need to be thinking about ECMO again. Always remember, the underlying cause should be reversible or treatable. So when are we starting to worry about treating ECMO? So when the tissue perfusion is being compromised. So when do you say tissue perfusion is being compromised? So when the lactate is rising, the mixed venous is falling, the cardiac index is less than 2, the pH is falling, increasing oliguria, which is telling you the end organ damage is setting in, inotropy requirements are going up, and the Murray score is worsening. So these are all markers of worsening tissue perfusion. So when do you start selecting patients for ECMO? So if your oxygenation index is greater than 40. So what is OI? OI is basically FiO2 times the mean airway pressure times 100 divided by the PaO2. So when this is giving you a number greater than 40, then you are in ECMO territory. Patients with a high mortality risk with conventional therapies, a Murray score of 3 to 4 is also an indication for selection for ECMO. The Murray score became famous during the Caesar trial. It's basically got 4 points along with 4 parameters which you need to score on. Firstly is the PaO to FiO2 ratio, the number of quadrants of the X-ray which are affected, the amount of PEEP which is being used, and the compliance of the lung on the ventilator. So when your Murray score is about 3 to 4, then you are in ECMO territory. Inability to maintain a plateau pressure of less than 30, which means that barotrauma is imminent. Refractory hypercarbia with a pH of less than 7.2, which means all your conventional mechanisms of trying to alter gases has failed. Failure to improve with rescue therapies such as high-frequency oscillation or prone positioning. Presence of a significant air leak or a bronchopleural fistula would all combine to a selection criteria for initiating people on ECMO. Now, this is a slide which is depicting the data from ELSO. So what I would like to draw your attention to is basically the last column, which is basically telling you that the total amount of survival to discharge or transfer is 56% across all groups. As you can see, the pediatric groups fare slightly better than the adult groups. However, the thing I'm trying to highlight here, the morbidity and mortality is quite high with this therapy. And this is a slide depicting the entire world's data. So coming to basic configurations on ECMO, the VA ECMO, when you initiate it peripherally, you have a multi-stage drainage cannula, which is put through the femoral vein, which sits in the RA. And then you have your return cannula, which is again in the femoral artery with a distal perfusion cannula to make sure that your peripheries are being perfused. Alternatively, if you want to avoid a DPC, you could stitch a side-on graft onto the femoral artery, and thereby you could flow through that conduit. In central VA ECMO, it's pretty much bog standard. Open the chest, RA and aorta return cannula, and then you're initiated on ECMO. LV venting. Now, this is a very, very important aspect of VA ECMO. Now, it is quite important to make sure that your LV is not full and it is completely decompressed when you are on an ECMO run. The reason you want to do this is primarily because you do not want the Frank-Starling's law to get activated. Now, when the Frank-Starling's law is activated, then you're not exactly providing adequate rest to the myocardium. The Frank-Starling law states that the force of contraction is directly proportional to the initial length of the muscle fiber. So if you have a completely decompressed ventricle, then there is no chance of the actin and myosin to initiate a contraction, and thereby you rest the ventricular mass completely. So this is quite important. There are several ways of venting the ventricle, but that's another topic on its own. The gold standard, however, remains an LV apical cannula, which is shown in the picture, which will very nicely decompress the left ventricle. Alternative methodologies include a PA vent, creating a septostomy, or sometimes people might even consider using an IABP as a surrogate vent, although it is not recommended practice. So when you put in an LV vent, you please make sure that you have a flow probe monitoring the flow coming out of the LV vent. Now, when the LV vent is inserted, the LV will be on a Y connector, which is draining into the RA. Thereby, this is the flow out of the patient into the ECMO circuit. You need to have a flow of around 400 ml per minute in an adult patient to prevent any form of clotting to occur inside the vent cavity per se. When you come to VV-ECMO, if you are using a conventional peripheral methodology, you have a multi-ported venous cannula to drain through the femoral vein, and you have a cannula inserted through the superior vena cava as a return cannula. Do bear in mind, a minimum distance of 10 to 15 centimeters between the two cannula tips is recommended practice to avoid any form of recirculation. However, there is another methodology which you could use, which is a dual lumen cannula. There are multiple vendors in the market like Avalon or Origin, which you can pick and choose depending upon your locations. And then you can have a dual lumen cannula inserted into the IJV. Now, it's quite important to make sure that the return cannula tips are placed in such a way that the flow always goes back to the tricuspid valve. Now, this cannula is usually recommended to be inserted under fluoroscopy guidance along with echocardiography, transesophageal or transthoracic, take your pick. But it is always very important to put this cannula directly under fluoroscopy because if it has got a high incidence of rupture, it can cause a lot of trauma, and it's quite a big size cannula. So it is always safe than sorry in this kind of methodology. There are people who have used an Avalon cannula or an Origin cannula through a left subclavian vein access where they stitch an end-on graft and then the cannula is inserted through that. Now, predictors of mortality. As per ELSO, age, female gender, a high actate level, COPD, renal dysfunction, liver dysfunction, and pre-procedure stroke are all predictors of mortality. The indications for cardiac are multiple. It's all listed on the slide. The commonest indication for cardiac is post-cardiotomy cardiogenic shock. Myocarditis per se is one entity which does really well on ECMO. Apart from that, ECPR, poisoning, drug toxic overdoses, sepsis, cardiomyopathy, decompensated heart failure all add on to the list for indications of cardiac. Now, when you initiate this therapy, which has got a high morbidity and mortality, you would like to know what are the odds of survival for your patient. So is there a tool to predict the odds of survival? So the Royal Alfred Hospital in Melbourne, the Department of Intensive Care there, came up with something called a SAVE score. SAVE stands for Survival After VA ECMO. And as you can see, the score has got parameters on the right side of the screen, which are pretty easy. They're just sliding parameters to the right or left. And when you do your correct data entry there, it generates a graph. Like, for example, this particular patient, the SAVE score is 2, which means the survival of this patient after an ECMO run is anywhere between 50 to 60%, which is quite well within the ELSO data. So this will give you the confidence as a clinician that yes, maybe if I initiate ECMO for this particular case, the outcomes are likely to be good. Now, there is yet another form of ECMO, which is called the hybrid ECMO. Now, for an hybrid ECMO, you're basically putting a Y connector dividing. One is going into the arterial system and the other end of the Y is going into the venous system. So when do you consider using hybrid ECMO? It's when you have things like a Harlequin syndrome or a Nautz syndrome, which you can encounter with VA ECMO. This is most commonly seen in peripheral VA ECMO. However, its incidence can also occur in central VA ECMO. Now, in peripheral VA ECMO, when you are actually giving the return of flow of blood, oxygenated blood through the femoral artery, and this is getting met at a particular point in the descending aorta with deoxygenated blood. Now the question is, why is there deoxygenated blood in the ascending aorta? The reason for this is When your heart has recovered to a certain extent, but your lungs are still lagging behind, the contractility of the heart will push the suboxygenated blood, which is traversing the lung, into the ascending aorta. And the point at which the deoxygenated blood mixes with the oxygenated blood is defined as the watershed area. Now, depending upon how much the LV has actually improved, that particular watershed will start going south. And as the LV starts going down in functionality, that watershed moves north. So the implications of this watershed is you would have the lower half of the body, which is completely thriving and pink, whereas the upper half of the body and the brain would be getting deoxygenated blood, which is not a great idea. And initiating hybrid ECMO will ensure that a substantial quantity of oxygenated blood is traversing down the IJV, which will make sure that your brain is getting adequate oxygenation. So this is a treatment for this particular Harlequin syndrome, as it's popularly known, and that's one of the indications for utilizing hybrid ECMO. The indications for pulmonary now are quite substantial as well. Pulmonary ECMO became quite famous during the recent COVID and the H1N1 pandemic. Now, just like VA ECMO, all clinicians would like a scoring system for you to decide whether VV ECMO is the right therapy for your patient. So just like the SAVE for the VA ECMO, you have something called a RESP score, which stands for Respiratory ECMO Survival Prediction Score. Again, it's got lots of parameters which are quite easy to fill up, and you can keep tick boxing this. This is an online tool. And then once you keep tick boxing it, you would start developing a score, which is an AI generated score. So once you finish all your scoring, it's quite important that you put in your data correctly. And once you do that, it generates a score, which is like, for example, the data I have put in generates a score of 3 points, which means that this particular patient, if your data entry is right, would have a 76% chance of in-hospital survival. Now, this is quite a useful tool for clinicians to have, because occasionally you are thinking about ECMO territory late in the night where a phone a friend may not actually be accessible. So if you have some form of evidence-based grading tool like the RESP score, for example, it gives you a reasonable amount of confidence to initiate ECMO in a patient, because this is a very resource draining and high financial requirement therapy. So this gives you that moral support that yes, you are doing the right thing for your patient. Where there are indications, there will always be contraindications. The relative contraindications are something which will depend on your situation on the ground. Now, in relative contraindications, as you can see, many of these things are quite nebulous and they can be manipulated depending upon your clinical need. However, the most important thing to bear in mind is the absolute contraindications, where there is significant neurological injury, or there is active bleeding or coagulopathy, and where there is terminal disease with short life expectancy. In situations like this, it's an absolute no-no to initiate any form of ECMO. The key to ECMO success is a multidisciplinary team. Now, the multidisciplinary team consists of perfusionists, pharmacists, physicians, advanced critical care practitioners, respiratory therapists, and of course, nurses. Communication and attention to detail is key, because you need crystal clear communication for the team to understand and act on those orders. Early initiation of therapy before end organ damage is key to a good outcome. Thank you so much for your time.
ECMO. We will go on to the next talk, that is ECMO. May I request Siddharth Raju to start his presentation. Siddhartha is currently working with us, and he's quite enthusiastic and taken care of a lot of ECMO patients. So we will see what he's going to tell us about the troubleshooting in ECMO. Thank you very much, and stay back till the end. Siddharth, please continue.
Good evening, everyone. I'm going to talk about what can go wrong with ECMO and troubleshooting. My name is Dr. Siddharth. I'm the Associate Consultant, Adult Cardiac Intensive Care, Muralidhar. What is Murphy's law? Murphy's law is what can go wrong will go wrong at the worst possible moment. Most of the intensivists agree with this. What are the key lessons? First, we have to get the indications, inclusion criteria and exclusion criteria right. We have to get the cannulation right. Bleeding, it happens on ECMO. We have to manage it judiciously. We have to be ahead of the game and anticipate the complications and prevent them from happening rather than handling the complications. Teamwork is very important, and it's very important. ECMO cannulation. ECMO cannulation is very important. We have to use ultrasound and fluoroscopy to do the same. And at the same time, 2 persons is better than 1 person. We have to avoid rewiring of the lines. Asepsis is of utmost importance. Attention to every detail is very important. What are the circuit problems we might face? Routine problems like access issues, where there might be flow fluctuations, kickback of the venous line, hemolysis and raised plasma-free hemoglobin. Catastrophic problems like pump failure, suck down, arterial or venous decannulation, circuit rupture, air embolism, cardiac arrest on VV-ECMO, with VV-ECMO, LV distension and cardiac chamber thrombosis. What are the flow fluctuations in the access pump? Why do they happen and what it is? Venous pump is unable to maintain a constant flow rate, that is called flow fluctuation. And why does it happen? Most of the time it is due to hypovolemia, or there might be a circuit thrombosis. So fiddle around the line, find out the reason and correct the reason. What is kicking line syndrome? When the venous line keeps wiggling randomly like a fire hose. This occurs due to the massive negative pressure, which causes the vein to collapse over the access cannula tip and causes the atmosphere pressure to straighten the tube. The solution is alter the cannula position and correct the volume status, and this will be sorted out. Hemolysis on ECMO does occur. It occurs when the access pressure is above 250 millimeters of mercury, which will cause shear stress and strain on the RBCs and cause hemolysis. This leads to increase in the LDH, increase in the reticulocyte count, increase in the plasma-free hemoglobin. Always target the plasma-free hemoglobin to less than 0.1 gram per liter. What are the causes for access problems? Kinking of the cannula, as you can see in the diagram, or it might be due to decreased venous pressure, due to poor intravascular volume, or increased intrathoracic pressure and increased intra-abdominal pressure. How do you manage the access issues? First is troubleshoot the circuit, see whether is there any kinking or circuit thrombosis, etc., which is leading to the problem, and correct the volume status, adjust the pump RPM and turn it down slightly so that there is no vigorous suction happening over the access cannula tip. Usually a small cannula tends to misbehave above an RPM of 3000. So in this situation, add an additional cannula to increase the flows, or you also take a call on repositioning the cannula. Circuit thrombosis, very little can you do once it happens. Always prevent it from happening. Pre-membrane clots don't cause much issues. Post-membrane clots are dangerous. They will cause systemic embolism, and hence ensure adequate anticoagulation to prevent them from happening, and arrange adequate staff for exchange of the thrombosed circuit component. Suck down. This is complete obstruction to the flow of the venous access circuit, resulting from sudden collapse of the central vein over the access cannula tip, which leads to a massive negative pressure and the loss of forward flow. This might lead to a cardiac arrest or hypoxia. So circuit rupture. In this suck down, you decrease the RPM speed to 1000 and increase the volume status. That's how you correct it. Circuit rupture. How does it happen? Usually it occurs due to the breakdown of some random circuit component, be it tubing, oxygenator, pump head, etc. How do you manage it? Manage it by Vinnie's protocol. If the circuit rupture is very small, wear a sterile gloves and plug the hole with the finger. If the rupture is unfringeable, clamp on either side of the circuit and immediately arrange things to change the circuit immediately. Start CPR in case of VA and manually ventilate in case of VV. Change the circuit as early as possible, quickly, to prevent catastrophic events, and replace the lost blood because there will be loss of blood. Air embolism. This tends to happen in circuit rupture or access decannulation accidental. The circuit will deprime quickly, and hence the pump will get filled with foam and the pumping will not occur. The good news is there won't be further air embolism. The bad news is there are loss of output. This will lead to hypoxia or cardiac arrest, and we have to manage it accordingly. So air embolism to systemic circulation again causes the same systemic embolism features. We have to be careful. Watershed and differential oxygenation, or the famously called Harlequin syndrome. It occurs in peripheral VF commonly. And what happens here is the heart has recovered, but the lung is not yet recovered. The lung is not oxygenating well. So in this situation, what happens, whatever the blood is passing through the lungs, it's not well oxygenated and reaches the LV. And the LV, since it has recovered, it will pump the deoxygenated blood into the ascending aorta and the arch and leads to north-south syndrome. What happens here? As you can see, the LV has recovered, it received the deoxygenated blood, and the deoxygenated blood has pumped into near the arch, so the brain and coronaries are getting deoxygenated blood. So how do you sort this issue? We have to wait for the lungs to recover. For this reason, we will have an additional VV cannula, venous cannula, into the right side of the heart and pump oxygenated blood, so that this oxygenated blood reaches the LV and the oxygenated blood gets pumped into the arch and ascending aorta. Hence, the coronaries and the brain will get oxygenated blood. This is the solution. What is partial Harlequin syndrome? Partial Harlequin syndrome happens in central VA-ECMO, where the aortic cannula is sitting at the arch tip, as you can see in this diagram. As you can see, this is the brachiocephalic artery. This is the ascending aorta. This is the RC and the left main column. Here, as I told, the heart has recovered, the LV has recovered, but the lung is recovering. Hence, the LV is pumping deoxygenated blood. Since the cannula tip is near the arch, this only the oxygenated blood is reaching beyond the brachiocephalic artery. Before that, the brachiocephalic artery and the ascending aorta are having oxygenated blood. Why it is important is the patient will pass the RAM study, but when you are weaning, you will fail. So again, we have to change to hybrid configuration, VAV, additional venous cannula and oxygenated blood into the right side of the heart, so that oxygenated blood reaches the LV and it is pumped into the ascending aorta and the coronaries get oxygenated blood. So, and we have to wait for the lung to recover. Once the lung recovers, then we can plan for, again do the RAM study and plan for weaning. LV thrombus. Nothing much we can do once it happens. We have to make sure it is extracted before a systemic thromboembolism occurs. Routine echo needs to be done on a regular basis to rule out the same. Always use a vent when it is deep prophylactic to avoid this complication. What are the ventilation issues you might face? Optimal ventilation strategies for VA-ECMO are not established. Rest the lung strategy in VV-ECMO cannot be applied automatically. The amount of PEEP, FiO2 and adequate ventilation is important to maintain coronary and cerebral oxygenation. Chest physio and nebulization should be beneficial and should be used on an individual basis. What are the problems which we face due to the PEEP? High PEEP causes decrease in the venous return and hence reduction in the cardiac output. It also increases the pulmonary vascular resistance and increases the RV afterload and affects the RV function, and it decreases the LV compliance. So we have to be careful. What happened here? This is one of our ECMO cases in our ITU, where we received post-ECMO in the ITU. Patient X-ray looked fine, as you can see. After half an hour to 1 hour, the nursing staff told that there is repeated alarms on the ventilator and adequate tidal volumes are not being delivered. we immediately auscultate the patient. There is decreased air entry on the left side. So we get an X-ray done if there is complete whiteout on the left side. After discussion, we come to a conclusion that there might be a mucus plug. Hence, we do a bronchoscopy. Bronchoscopy was clear. As you can see, there is external compression. So what do we do here? We immediately take to OT for re-exploration. We find a bleeder, evacuate the hemothorax, place a drain. As you can see, the lung is cleared out and the X-ray is fine. So in ECMO, you have to anticipate bleeding and handle it accordingly. What are the other common problems? Like atelectasis needs to be managed with adequate physiotherapy. VAP or pneumonia need to be managed by adequate antibiotics. Pulmonary edema, we have to maintain with adequate diuretics and volume status. Okay, identification of the problem is important because it will lead to weaning failure. Nursing and physio issues. Nursing and physio is very important because a well-trained nurse and physio help in recovery of the ECMO patients quickly. All the nursing staff who handle ECMO should be well-trained and they should be handle the complications, identify the complications quickly and inform the doctors immediately for handling the same. And good nursing and physio make a huge difference because they are the ones who identify the small changes in dynamics that occurs. They are the ones who give care to the patient. And also physio play an important role. Regular physio is important to prevent atelectasis and VAP from happening. And also they play an important role in mobilization. In our ITU, most of the patients we do mobilize. And on ECMO, once they are extubated. And most of the patients we extubate as early as possible. And once we extubate, we try to mobilize them to chair first. If they're tolerating the chair well, then another 24 hours later, we mobilize. Why well-trained staff is important is somebody has to hold this acute, somebody has to hold the patient. At the same time, somebody has to monitor the flows. That's why a well-trained staff is there. It will be very, very easy. Okay, that's why it's very important to have a good group of nursing staff. And last but not the least, heart and lung is a single unit. They are not separate. Both are interlinked to each other. Each organ affects the other very quickly. So we have to think them as a single unit. Thank you.
Thank you very much, Dr. Raju. Now I would like to request Dr. Girish for his talk on hypoxemia on VV-ECMO. Dr. Girish is a consultant anesthesiologist in adult cardiac critical care unit, as I was told. He has got great experience on ECMO. Over to you, Dr. Girish.
Good evening, everyone. I am Dr. Girish. I'll be talking about how we deal with hypoxemia and VV-ECMO. So I'll be talking this as a case-based presentation. So we usually operate, in our hospital, PT gets usually operated, which is a operative procedure name for pulmonary thromboembectomy for CTEPH case, which is chronic thromboembolic pulmonary hypertension, which is a complication of pulmonary embolus. As you can see, patient had to be initiated on VV-ECMO intraoperatively, and this is the first ABG which shows the PO2 of 55, which is above the VV-ECMO targets, and lactate is rising, so everything saturation is 91. Before we move on, I would like to talk about how in VV-ECMO the delivery and consumption gets affected. So in this case, the normal DO2 is for a 70 kg patient would be with a 15 ml per kg per minute would be 1 liter. And for VO2, that is the consumption for around 70 kg patient, which is around 3 ml per kg per minute, would be around 210. A ratio of 3:1 to 5:1, that means for every 100% saturation, 20% of that is utilized and remaining 50 to 70% remains in the venous side. But if the oxygen consumption to delivery starts reducing, it becomes 2:1, the anaerobic metabolism starts setting in. If it starts to rise 4:1, there could be a hypermetabolic state which is setting in, or a high cardiac output state, or a sepsis state which is setting in. So with the ABG which I showed, let's see the arterial oxygen content. Arterial oxygen content is 141 ml or oxygen per liter. The pre-oxygenator content is 99.82. The post-oxygen content is 163. With this, we can calculate the total flows, which is around 6 liter. So the native flow would be 2 liter, minusing the total flow minus VV-ECMO. VV-ECMO flow we have set at 4 liters with an RPM of 3,500. So with this, calculating the oxygen delivery for this patient is 852. Oxygen consumption is 200. Considering for a 70 kg patient, we are considering a 3 ml per kg. The oxygen delivery consumption ratio is 4.05, which is good for this patient. But after some time, the staff notices the saturation on the monitor has dropped below 80%. So it does an ABG. ABG shows a PO2 of 38. And the tidal volume on the ventilator has dropped below 100, and there is blood coming out of the ET tube. She calls me, I ask for an X-ray. X-ray, see, there is complete whiteout of the lung. That means the native lung function has become 0, and the whole oxygenation is taken over by the VV-ECMO. With this, let's calculate the oxygen content. For arterial blood oxygen content is 115. The pre-oxygenated blood oxygen content has dropped to 77. And the post-oxygenator, because since oxygenator is working well, is 163. With this, total flow has become 9 liter because there is tachycardia, there is increased cardiac output. So the native venous flow has become 5 liters. If you calculate the oxygen delivery is 1 liter, there is definitely increase in the oxygen delivery, but the consumption has remained the same. So the oxygen delivery by consumption ratio is 4.9. That means there is extra oxygen delivered to the patient more than what it is required. So in this, has been definitely a gain in systemic oxygen delivery, higher cardiac output, despite a decrease in arterial saturation content. If the patient's systemic oxygen is normal, systemic delivery is perfectly adequate and full aerobic metabolism is supported, even though the arterial PO2 is 38. At present, no changes might be required at this stage if your lactate is holding on ABG and your DO2 by VO2 ratio is normal. Consider in this situation, the extraction has become more and more and the oxygen starts to fail. Oxygen starts to fail. The photo on the left side, as you can see, there is bright red color on the right line and the drainage cannula is darker. Once the oxygenator starts failing, the oxygenation content in that starts reducing, so that the color difference between the two starts damping out or blurring out. So with this situation, if the oxygenator consumption is reduced, as you can see, it has become 134 now. With this, if I check the total flow, we have reduced the high cardiac output state, we have increased the decreased the rate. So venous flow has come down to its normal 2 liters. So with this, oxygen delivery is 690, consumption concerning it normal. The oxygen delivery by consumption ratio has dropped below 4 and it is 3.2 now. That means we are very close to starting to develop anaerobic metabolism. Other technical issues have to be sorted out, like the inflow cannula of oxygen, and that's why we always keep it at the top. The rote of the flow meter, where the flow should be checked, the FiO2 should be checked, the ventilator settings have to be checked, the ventilator oxygen connection should be checked. All those technical issues have to be sorted out. If all these things are not there, then we might be dealing with what is called recirculation. Recirculation is when the blood which is coming out of the oxygenator we usually goes into the left ventricle and goes into the circulation. And the drainage cannula from the femoral, which is drains the deoxygenated blood and the oxygenator. But if there is recirculation, the blood goes into the left, but most of the blood might also come into the drainage cannula and it might recirculate in the system. Depending upon the degree of recirculation, depending upon the percentage of recirculation, the effects starts to appear. For a recirculation of 20-30%, the effects may not be seen, but if the recirculation starts rising, the effective flow which goes into the patient might be reduced, that is, the oxygen content of that flow will be reduced, so the hypoxia might set in. There are various methods to estimate the percent of recirculation. The formula would be pre-O2 minus central oxygen O2 and post-oxygen O2 and with venous O2 into 100. You can use the central venous method where you can draw blood from the superior vena cava and inferior vena cava, or you can use the formula where SVO2 is equal to S pre-O2 when you turned off the gas and ventilator used to achieve an equivalent SAO. Other thing is thermodilation, where you inject whole saline into the reperfusion limb and thermistor tip catheter detects changes in temperature in the drainage limb. Or the best method would be to serially check the oxygenation in the pre-oxygenator flow, and serial increase would suggest there is definitely clinically relevant recirculation. So there is no clear-cut guidelines to where to keep the two cannulas, how separate they should be, but keeping at the distance of more than 15 centimeter in an adult patient would prevent the degree of recirculation. Other thing, consider there is no recirculation, oxygenator is working fine, and you've checked all the technical issues. The other thing we can do is increasing the hematocrit by transfusing. So as we all know, the content of oxygen directly corresponds to proportional to hemoglobin. The dissolved oxygen content is very low, depending upon the PaO2. So a situation where we do not have a hemoglobin, so the bound oxygen to hemoglobin would be very, very less, and only a dissolved oxygen would be left. So oxygen dissolved, to reach a normal consumption of 3 ml per kg per minute, you would require a cardiac output of 80 liter without hemoglobin to achieve this feat, which is probably impossible for the human heart. So here's a graph which shows how increasing hemoglobin would give us a lesser ECMO flow and higher saturation. As you can see, if we keep on increasing the hemoglobin to 14 or 15, about all, the ECMO flow to reach the oxygen saturation above around 90% would be a 4 liter. So consider target is about 80 to 85%. You would require 3.2, 3 or 3 to 3.5 of flow here. But if you keep a hemoglobin low, the content reduces to, in order to achieve greater oxygen saturation, you need higher flows, and higher flows always comes with a cost. There is something unique happens in VV-ECMO. The blood which is coming out of the oxygenator does not have carbon dioxide, or it is normocarbia, and which goes into the lungs is superoxygenated, is supersaturated. So according to Bohr's effect, when there is partial pressure of carbon dioxide more is high, the affinity of the hemoglobin to oxygen reduces, the hemoglobin gives away oxygen. But in VV-ECMO, when it crosses the lung, the partial pressure of the carbon dioxide is low, but even then, the hemoglobin does not know what to do with the extra hemoglobin, extra oxygen, which is supersaturated. So it starts giving away oxygen into the lung. That is called extraction. So if extraction is more in the lung, that is, the lung takes up majority of the share because it's the first organ which the blood comes in contact. As it passes on to the left, there could be hypoxic state developing because the blood oxygen content might be less to sufficient to deliver it to the kidney, brain, and other things. Major issue would be hypoxia of the brain. So By increasing the hematocrit in 24 to 48 to 72 hours, the 2,3-DPG develops. The blood gets superoxygenated. So whatever the extraction happens in the lung happens, but there will be more oxygen will be available for the brain and other tissues to get perfused. This is very unique to VV-ECMO. So with this, if consider the consumption has become more, so as we have seen, probably our delivery is 852, but the consumption has become 300. So the oxygen extraction has dropped below 2.84. That means the anaerobic metabolism has set in. We have done everything. So in our case, we would be doing to increase the lung contribution. Increasing lung contribution either by bronchoscopy. In our case, since there is a lot of blood and which the patient has had a pulmonary hemorrhage, there is a lot of clots, a routine bronchoscopy might not help, might require a cryobronchoscopy. This is the photo of clots removed from one lung, left lung only. As you can see, the anatomy of the bronchioles are all clearly defined. In CTEPH case, you might have to require the embolization of the culprit collateral vessels. And in ARDS or after cryobronchoscopy, if there are black in the X-ray of the patient, you might do a prone ventilation so that the oxygenation and gas exchange improves. But in the X-ray, what I've showed, the proning such patient would not help. But if there are black things, it will be helpful. So my patient progressed to currently still sedated and paralyzed. So the PO2 has gone up to the ABG. The lactate has gone up to 3.3. The PO2 is 45. We have increased the hematocrit to 45, 14 hemoglobin. Urine output is good. Single vasopressor support. You should accept this and follow the above steps. But if the pupils have started to become, the urine is getting affected, the patient is on dual vasopressor support, lactate is rising, patient is bleeding again or dropping, that means we'll have to look for other options. Other options would be chlorofluorocarbon injection, which is supersaturated fluid with oxygen into the ET tube so that the lung takes extra action. And Protect Duo, which is a special cannula, which is percutaneously inserted into the IJV and into the PA catheter, just to be just below the bifurcation so that it reduces the load of RV. Conversion to VAV-ECMO or cooling the patient. Targeted temperature method, according to recent article in the AHA, does not show any benefit in cooling the patient oxygen delivery and consumption between 32 to 36 or a normothermia after correcting the fever. Thank you.
Thank you very much, Dr. Girish, for excellently explaining the causes and how to remedy hypoxemia and VV-ECMO. Last but not the least, another important topic of complications of ECMO, dark side of ECMO by Dr. Medha. I request Dr. Jumana to introduce Dr. Medha, please. Dr. Jumana.
Sorry. I welcome Dr. Medha Mozumder, Junior Consultant and Adult in the Adult Cardiac Critical Care Unit at Narayan Hridayalaya, Bengaluru. She has done her fellowship in cardiac anesthesia under Indian College of Anesthesiology and has done her post-graduation from D.Y. Patil University, Kolhapur. Dr. Medha, please start.
Good evening. I'm Dr. Medha. I'll be talking about the complications of ECMO, the dark side. Neurological complication. ECMO is associated with neurological complications such as intracranial hemorrhage, ischemic stroke, seizures. VA-ECMO carries a higher risk than VV-ECMO because there's a higher risk of embolization in VA-ECMO because the blood is pushed into the arterial system of the body. Also, a higher level of coagulation is required to run a VA-ECMO. Types of neurological complications. Hemorrhagic complication. Intracranial hemorrhage is a known and a common complication. The incidence of intracranial hemorrhage in VV-ECMO is about 3 to 6%, and in VA-ECMO is about 1.8%. It can present as intraparenchymal, intraventricular, or subarachnoid hemorrhages. Ischemic complication. The incidence of ischemic complications in a VV-ECMO is about 1.8%, and in VA-ECMO is about 3.6%. Multifactorial etiology is present for ischemic complications such as large vessel occlusion, hypotension, hyperperfusion, thromboembolism, and septic embolism. Seizures. Because of intracranial hemorrhage as well as ischemic stroke are always associated with the development of seizures. The incidence of seizures in VV-ECMO is about 1.2% and in VA-ECMO is about 1.7%. Hypoxic encephalopathy. The inadequate delivery of oxygen to the brain results in hypoxic encephalopathy. This delivery of inadequate oxygen can happen because of the events before the initiation of ECMO and can happen after the initiation of the ECMO when the ECMO fails to deliver enough oxygen to the brain. Cerebral herniation syndrome. The large hematomas as well as strokes cause increase in the intracranial pressures and increase in the cerebral edema, which then puts the patient at risk for cerebral herniation syndrome. Brain death, large hematomas and increasing cerebral edema can cause put the patient at risk for brain death. Neurocognitive outcomes for following ECMO. Long-term neurological outcomes that are associated with critical illnesses are also seen in ECMO patients, such as impaired memory, motor disability, psychiatric disturbance, chronic pain, visual deficits, neurosensory deficit, hearing loss, and post-intensive care syndrome. Gastrointestinal complication. Gastrointestinal bleeds can be seen as hematemesis, melena, hematochezia. Incidence is about 0.6 to 7% of the cases. The reasons for GI bleed are imbalance between procoagulant and anticoagulant pathways, AV malformation, sepsis, and multi-organ failure. AV malformation can occur because of the malperfusion of the intestinal mucosa, which causes reconstruction of the in the vascular network of the intestinal mucosa, which puts the patient more in risk of bleeding. Sepsis and multi-organ failure causes platelet activation, which causes coagulopathy factor consumption, which puts the patient at an acquired coagulation factor depletion state. We start a regular infusion of PPI. When we start regulation of PPI, basically this results in decrease in the amount of gastric acid formation. This thus helps the Clostridium difficile in our gut to propagate and be present. And thus these patients are then at risk of C. diff infection in the future. Temistine, which is a ferroacrylate 1% sterile antiseptic solution. Basically, it is a topical hemostatic and a local antiseptic solution, which basically activates the thrombin to form clots. It can be used during endoscopy as a spray, or it can be used through the NG tube for the patient. Correct coagulopathy, endoscopic hemostasis. This can be included, such as local infiltration of the desired place with adrenaline or sclerotherapy, or clipping of the desired vessel. Point of care testing such as TEG and ROTA. This is basically how the TEG looks like, and the ROTA. Acute liver dysfunction. Early liver dysfunction is usually an independent risk factor for poor outcome. Acute liver failure is a known complication. Total bilirubin, alkaline phosphatase, and low albumin are all associated with long poor-term survival. Pathology of cardiac hepatopathy is due to impaired arterial perfusion caused by acute liver failure, passive congestion resulting from back pressure secondary to right heart failure, and development of hypoxic hepatitis. Now, in liver dysfunction, the LFT generally shows a cholestatic nature, which means there is increase in alkaline phosphatase, increase in total bilirubin, and decrease in the albumin. If the patient has hypoxic hepatitis, there is an increase in the transaminase enzyme to about 20 folds than what is the normal level. Otherwise, in acute liver failure, they have only a moderate increase of the transaminase enzymes. Management is acute liver failure is hepatoprotective drugs, prudent use of paracetamol, surveillance USG abdomen and pelvis, regular amylase, lipase, lactate, and LFT, bowel movements with enema. acute kidney injury. AKI is a known complication among patients treated with ECMO. The reported evidence of AKI on ECMO varies from 26% to 85%. Severe AKI requiring about RRT is about 45%. Patient-related variables are hemodynamic instability, cardiac or respiratory failure, severe hypoxemia, SIRS, sepsis, high vasopressor support, exposure to nephrotoxic. ECMO-related variables are circuit-related, reduced pulsatility, ischemic reperfusion injury. Circuit-related can be thrombus or microthrombi or malposition of the cannula, which can cause venous congestion. Reduced pulsatility is generally seen in VA ECMO because the continuous flow of the VA ECMO generally can affect the renal cortical blood flow. Ischemic reperfusion injury occurs when initiation of ECMO suddenly causes increase in the microcirculation of the previously hyperperfused tissues, which then can cause some amount of ischemic reperfusion injury. All this can result in fluid overload. Fluid overload is basically a determining factor for starting renal replacement therapy. Renal replacement therapy not only causes decrease in the fluid, but also helps in improving the renal metabolic, helps in reducing the load of the renal metabolic requirement, as well as flushes out inflammatory factors. Management of AKI is continuous renal replacement therapy, CRRT, sustained low efficiency dialysis, SLED, or intermittent hemodialysis, IHD. Liver ischemia. Liver ischemia in patients are supported on peripheral ECLS is a known complication. The ELSO in its latest report shows about 1% incidence of limb ischemia. Limb ischemia can be seen with larger cannulae more than 20 French, female gender, younger age, peripheral vascular disease. Hemodynamic instability, higher vasopressor level, and endogenous catecholamines form a low flow state, which can cause limb ischemia. Hemostasis, distal artery compression compartment syndrome can also cause limb ischemia. Percutaneous cannulation can injure the common femoral artery and the iliac artery, which can in perforation, rupture, dissection. And thromboembolic event, which is generally seen in patients who have diabetes mellitus, COPD, or asthma. Prevention of limb ischemia in peripheral VA ECMO. We place a DPC antigrade reducer sheet, which through an introducer sheet of 6 to 8 French. The DPC per se is from 5 French to 14 French. Our introducer sheet is only 6 French to 8 French. We usually put the DPC cannula in the proximal superficial femoral artery and try to attain a flow over 200 ml per minute for adults. So place a flow probe on DPC, check arterial Doppler for distal perfusion. Contralateral veno-arterial cannulation. It is always better to put the cannulas in bilateral groin instead of putting all the cannulas in single groin, so as to prevent vessel compression and hyperperfusion of that limb. A combined surgical and percutaneous technique. This basically means that the femoral vessels are exposed by a groin incision, but the cannulas are inserted through incision which is lower to the groin incision, so that we can close the groin incision, which then prevents less infection, less bleeding, and better nursing care. Frequent checks of cannula root, avoid venostasis, avoid distal artery compression. Femoral vessel Doppler, which is there to do a bedside selection which match the arterial caliper to the cannula size. So basically, if the femoral artery is small, we put a side-down graft to it using a Dapton or Hemoshield graft, and we do so as to side-down graft so as to maintain flow rectally as well as antegrade on that vessel. Management of established limb ischemia. Consider DPC cannula on peripheral ECMO and putting a side-down graft on the femoral artery. Percutaneous DPC, check flow with fluoroscopy or flow probe. Change the cannulation side. Thromboembolectomy, decompression of the compartment, fasciotomy, and amputation, which is the last result. Pressure source. Patient with ECMO are at the risk of development of sacral HAPS both during and after surgery, with the reported risk as high as 16.7% and 29 to 29.5%. A modified Braden scale and Norton's both are used to measure to assess the risk, patient's risk of developing pressure source. The shearing force and compression force, both when they decrease the blood flow to the tissue, which then decreases the tissue's tolerance for pressure, and thus causes a difference in the gradient between the demand of the oxygen and the supply of the oxygen which is present, which then causes an increase in HAPI in patients. Interventions such as pressure relief, infection control, debridement, and dressing may be used, and a 5-layer silicone-bordered prophylactic dressing was shown to reduce sacral pressure ulcers. This is basically an example of a 5-layered silicone-bordered prophylactic dressing. Hemorrhage. Incidence of bleeding on ECMO is as high as 39.6%. The excessive bleeding is present then withhold the anticoagulants for 4 to 6 hours until bleeding settles. Keep patient warm and chase clotting screen. Prevention requires correcting coagulopathy, thrombocytopenia, careful titration of anticoagulation therapy, and repairing surgical source of bleeding. Goals are basically platelets more than 1 lakh, iron less than 1.5, fibrinogen more than 1.5 grams per liter, hemoglobin more than 10 to 15 grams per deciliter, and antithrombin more than 50 to 80%. Heparin-induced thrombocytopenia. HIT is an immunological complication of the heparin therapy. According to ELSO, HIT occurs in approximately 0.2% to 5% of patients receiving unfractionated heparin and less than 1% in patients receiving low molecular weight heparin. Two major tools that have developed are the 4T score and the HET, which is the HIT expert probability score. Laboratory testing suspected for HIT includes immunological assay and functional assay. The immunological assay are such as PF4 ELISA, which is basically in tests which are present in most institutions. However, the specificity is not very high for these tests. Functional assay is basically the gold standard test, which is the C14 serotonin release assay, which is which is very specific and sensitive to HIT. However, these tests are not available in all institutes. When a patient is suspected of HIT, the patient undergoes 5 phases. Day 0 is when all the heparin and the low molecular heparin solutions are discontinued. The platelets are still at the downward trend. However, the laboratory is not able to confirm it because there is no positive result. After 3 to 4 days of the patient being a suspected HIT, the patient enters a phase called acute HIT phase, where the platelet count is still on the downward trend. However, from this phase, the laboratory tests immunological assay as well as the functional assay, both are positive. After 7 days, 90% of the patients start showing platelet count recovery. So the patient enters then to the next phase, which is the subacute HIT A phase, where the platelet counts are on the upward trend. However, the laboratory tests immunological assay and functional assay, both are positive. 50 days after stopping the heparin and low molecular heparin, the patient enters what is called a subacute B phase, where the platelet counts have normalized. The functional assay is negative. However, the immunological assay is still positive. After 85 days of stopping, the patient enters what is called a remote HIT phase, where the circulating anti-PF4 and heparin antibodies are no longer detected. The functional and immunological assay are both negative, and the platelet count is normalized. When HIT is suspected, discontinue all forms of heparin, consider using non-heparin coated ECMO circuit, avoid vitamin K antagonist, diagnostic assay, immunological assay, and functional assay. HIT is confirmed. Is there further anticoagulation contraindicated? If yes, then we observe and reassess. Increase ECMO flows if possible. Consider IVIG and plasmapheresis. If no, then we check the hepatic function. If the hepatic function is normal, then we can start argatroban. If it is not, then we can start vivalirudin, danaparoid, and lipirudin. If the HIT is ruled out, then we generally reassess for alternate etiologies for thrombocytopenia. Thank you.
Thank you very much for an excellent presentation, Medha. I request all the speakers and moderators to come back. If there are any questions, we'll be happy to answer. Over to Murali as well.
Thank you, Dr. Suneel, for being with us this afternoon. And we had 6 major topics concerning fundamentals of ECMO being presented. It was well done. Thank you so much for all the presenters. And the comments from the panelists, from moderators, and any questions are there that can be tackled at this point of time. Jumana, Arpan, do you want to add anything or comment on the content of the talks? Suneel, Pooboni, your expert comments are the most welcome.
So I'll go first. Thank you
Yes.
so much, Girish, for that lovely talk on hypoxia. It was very well handled. And I think there's a lot of times when you get these queries where the PO2 is really low and
Yeah.
a lot of manipulation is done of the flows and of the systems. Excellent presentation, really something to learn from even at our level.
Thank you, ma'am.
Yeah. One comment, I really still feel that IABP does do a good amount of venting. And because in our Indian scenario, we'll end up putting IABP very early, even before initiating ECMO. It's a good, adjunct to have to a peripheral VA ECMO till we can figure out more invasive ways of venting. So that was from Dr. Sanjay's talk. Overall, a very lovely webinar. Over to you.
Thank you, Jumana. My question was to Girish as well. Girish, wonderful presentation. One question is, do you do these calculations bedside next to the patient? You have shown oxygen content and oxygen being used up, the flows, etc. Do you do for each and every patient bedside?
No, sir, not in each and every patient. When we start running out of options, when we have achieved the maximum flows we can achieve, and also we have increased the hematocrit rate, but we are not achieving the proper PO2, then we go to this method. Otherwise, routinely, we don't do it.
Okay.
Actually, I can just add a point here that we always concentrate or put our minds on the oxygen tension and oxygen saturation. I think in patients who are in VV-ECMO, we need to also consider what is the content, oxygen content in the blood, which is going to the peripheral tissues, because that is the one which carries oxygen to the peripheral tissues. And we also, that is one of the parameters which I think is of importance, especially in terms of VV-ECMO. Because we are increasing hemoglobin to increase the content of oxygen in the blood. So we need to know what the content is taking into the peripheral tissues.
Just a general question to Narayan Hrudayalaya, to Jumana and Arpan. How often you are using hybrid ECMO?
Sir, I feel that hybrid ECMOs get very complicated, and it is better to go to a central, configuration rather than trying VAV. A VVA, increasing the cannulation for getting better flows, yes, I think makes sense. Many a times I feel like putting in a double lumen cannula initially as a VVA for septic patients who come with, cardiovascular and respiratory downtime, and then at some point converting that to a VAV. If we are not meeting goals only with a VA. So the double lumen cannula acts as a great big access port initially, and it gives us flexibility to turn over to VAV if supposing we are not meeting the we are having harlequins, or to pure VV if the hemodynamic stability is achieved.
I totally support you. Other
Arpan,
institutions?
Arpan was supposed to answer. Arpan, are you there?
I think Arpan during the COVID times did put some patients on VAV. I'm not sure how happy he was doing that, because COVID, we had a lot of hemodynamic instability at the time of initiation because of the late windows and the pneumothorax.
We will ask Sanjay now. Sanjay, what's your statement on this?
Yeah, we do an average of about 120 to 130 ECMO runs in a year. And our incidence of requiring hybrid is less than 5%. And it's basically when we see a harlequin evolving, as that's when we start thinking in terms of hybrid. But generally, being a cardiac unit, our first go-to option is central VA ECMO with a LV apical vent, and that's what we would normally do. Just to clarify the point what Dr. Jumana had raised about venting with a balloon pump. The one problem with a balloon pump as a surrogate vent, especially when you are on peripheral VA-ECMO, is the fact that you've got one groin femoral artery which is taking the return back from the pump. And the other groin, you've got an IABP which is sitting in the descending aorta. Now your IABP, if it's going to run at 1:1 augmentation, and that means that 50% of the cardiac cycle, the blood coming through the femoral artery return line is not going to go up to the upper body. That's the first point. Second point is, if you develop a Harlequin syndrome, which means that you're getting deoxygenated blood from the native lungs, which is being pumped up the ascending aorta, your balloon pump itself, whenever it deflates, creates a venturi. And when it creates a venturi, the deoxygenated blood moves further down into the descending aorta, which has got two problems. One, you will exaggerate the Harlequin syndrome. Secondly, you will have a lot of spinal cord ischemia chances because the artery of Adamkowicz comes off quite high in the aorta. So these are the two negativities of using a balloon pump. However, you could cheat. You could put the balloon pump at 1:3 at 50% augmentation, which means that only in 1-3 cardiac cycles, you would not get blood flow going into the ascending aorta.
And
So
you'd
that's
have
the
the
way to
valve
cheat.
opening.
Yeah, that's one way to cheat with a balloon pump. But otherwise, we always tend to avoid an IABP. In fact, even if we have an IABP, as soon as we have the clotting under control, we tend to take it out.
I do agree with what Sanjay said. The problem with the IAVP as a vent, it does not come high up in the list of preferred choices of venting the LV when there's distension.
We actually in intensive care get stuck of course, if it's a cardiac surgical case, then all permutation combinations work. But in intensive care, we sometimes get stuck with the economics of everything and wanting to take the patient in for something more. So now my counseling has gone from, just counseling from ECMO to counseling to all subsequent scenarios and configuration changes or, right at the outset before we commit to an ECMO.
Yes, yes. Dr. Arpan, are you there? We need to hear from you. I think he's not there.
No, sir, he's not there, I think. He has left the meeting.
Oh. That's fine. So any other comments or questions?
Dr. Muralidhar, the ASA conference is in San Francisco, not San Diego.
It's in San Francisco. Sorry, I made a mistake. It's not San Diego, it's San Francisco.
Great. Thank you.
Thank you. Any questions or comments? We have 2 minutes to go to close the session.
I think the speakers did a great job. They covered most of the aspects and was a very good, thorough review. Excellent.
Thank you. Thank you, Dr. Bilani. Thank you. As I don't see any questions or comments coming up, it's time to wind up the session. I would like to thank Dr. Suneel Pooboni, Jumana, Arpan, and all the speakers, starting from Sanjay, Tejas, Suneel, Siddharth, Girish, and Medha for the excellent presentations. And starting from 2nd of November to 5th of November, we have the ICA Con 2023. Please join us. It is being hosted by Narayana Hudayalaya at Bommasandra, Bengaluru. Please join us. It's a 3-day event with 1 day preceding pre-conference workshops. It's well charted out by the St. John's people leading the scientific team, and it will be held at Narayana Hudayalaya, Bengaluru. With this,
So you wanted to get some video play?
Yeah. Is it available? Can you please play it?
Yes, sir. Yes, sir.
Thank you very much. That was the video of the event going to happen in November. Dates are 3rd, 4th, and 5th, with 2nd as workshop days. With this, I would like to conclude. Dr. Jayashri Sood, are you there? Will you be able to talk to us?
Yes, sir, ma'am is there.
Good evening. Thank you, Dr. Murli. And it's a great pleasure to be proposing the vote of thanks today. Indeed, an honor. We've had such a overwhelming webinar. In fact, many of us do not have so much of experience in the use of ECMO. Of course, during the COVID times we did have, but now some of us still continue to have, whereas others don't. So today was an extensive webinar covering all important aspects of the ECMO. And Dr. Kanchi has already thanked everybody, but I would like to say a special thanks to Dr. Suneel, Dr. Jumana, Dr. Arpan, and of course, Dr. Murli, and the speakers as well for their very, very exclusive and very crisp talks that they have given today. Thank you so much. And we hope to see you more often in our ICA webinars. See you all next week, same time on Wednesday. And of course, as Dr. Murli said, we would like to see many of you in the ICA Con in early November. And all those who are going to the anesthesiology conference, ASA this month, all the best, safe travels. Good night, everybody.
Good night, and thank you so much.
Thank you.
Thank you. Great job.
Thank you, everyone. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Good night. Thank
Good
you.
night.
Thank you.
Thank you, sir.
See you at both conferences.